All right, so this is week 11, week 11, I guess is what this is, since we didn't count spring break in our numbering. This week covers 2 chapters, special populations and health policy, so it's kind of a longer lecture for me as far as like number of slides, but I wanted to give you guys a chance to ask any questions you might have about your papers. We're grading them, are giving feedback right now on them. The next big thing is your interviews. So how many of you have set up your interviews? How many of you know who you're going to interview? Okay.
Put the hands are up and I'm like,
We have to wait.
I have like
until you read the questions before we.
Yeah, have you submitted yours?
I will tonight, but no.
Okay, so everyone who's submitted theirs as of this morning, I looked, I'd given feedback, okay? So I'll be checking those daily from now on so that I can get that feedback. Yes?
Yes. Can you, because I'm
You're
in the process of still doing the questions.
Uh-huh.
Are there any kind of specifications
Yes.
you want for the questions?
So some of you have more experience with qualitative interviewing. How many of you done qualitative? There are a couple things that you'll want to keep in mind, and that's the kind of feedback I've given thus far, is you want to ask questions that elicit people to talk. If you ask a question that's just like, do you think apples taste good?
Yes or no.
It's a yes or no question. You won't elicit very much feedback. So think about what you really want to learn. What are your thoughts about fruit that come off trees? And then that's what you want to know. If they like them, what do they like about them? You can have some yes or no questions with a probe. So does your practice provide prenatal care to immigrant women? Yes or no? Why or why not? Or what are the barriers to that work that you do? So you can have probes. You may say yes or no, but if you just have a yes or no question or a handful of yes or no questions, it's going to be really short. Interviewees, you are all different. You may have someone, even when you ask really good open-ended questions, may give you something short and sweet. So you should be thinking of some probes that if they don't quite, get deep enough, what would you ask to elicit more? Other people, you could ask them a yes or no question and they'll talk forever, okay? It's just people's preferences and how they interact. You do not have to record these. You do not have to transcribe them. You do not have to do a content analysis, okay? This is not like serious qualitative research. You wouldn't have enough time left in the semester to do all of that. For your paper, I would rather see you guys write like a narrative around it. So I spoke to Susie from JCMC about their Trauma One Center. She's worked there for 15 years. She's currently the blah, blah, blah. When I asked her questions about utilization of, well, I don't know. She told me this, and this. Instead of like writing, I asked her this question in quotes, and this was her answer. So make it more of the narrative. And it can be like, I found it really interesting that she said this. So you can talk about your conclusions or kind of what you pulled from what they said in that. So closed-ended questions, bad. Open-ended questions, good. Yes. right now.
So for my topic, when I be like interviewing someone, it's about the graduate medical education program and how it's affecting rural areas and non-distribution. So would I be interviewing, like I had in mind interviewing like my sister because she was in a rural area for med school and they had offered like after to do residency in that area, but she said no. With that,
So you'd want someone who is in a leadership position. So our first BWE speaker of this semester,
Rhonda from second year.
no, last semester.
Oh, last semester.
But who was the gentleman from last semester?
Steve Kilgore.
Yeah.
So he does a lot of recruitment for, I guess at the time it was Misha. So someone who like recruits physicians to, is that what you're doing, graduate medical education, or like getting physicians?
to come more to like to rural areas and how like maybe they could advocate to like pay more for residents.
Okay. Yeah, so that would be like more on the recruiting side.
Yeah.
I mean, you could, I think in your opinions part, like the last part, you could talk about how in your experience with family members, you found that there were barriers. You said a family member,
Yeah.
right? But I think you'll get richer information from a recruiter or someone in HR.
What was his name again?
Steve Kilgore.
And I could just contact him via email. Probably.
I would say.
And if you need his email, you might have it.
Yeah, I think maybe I don't remember.
Okay.
Or if it was, if I don't, then yeah, Kilgore, Kilgore.
Okay.
If you go to the BWE like on College of Public Health and watch to the very end of his PowerPoint, I'm sure it's contact
have it on there.
information. It's on his PowerPoint.
Because he had a lot of good information about the international medical graduates and then how they try to recruit physicians and different specialists here. I think he talked a little bit about that in his talk as well. Okay, I think Dawn and then
So let's say you turned in your questions, but then you already did your interview, but then you had closed-ended questions, but they still give you a lot of information. Is that okay? 'Cause,
Yeah.
I mean, Dr. Pack, I would ask him a question. And
oh yeah,
it was
that's
like,
fine.
It went to different answers to different things. Like he would answer all of my questions for the first question, and then I would have to like.
Yeah, that's fine. There are cases where students already interviewed, which that I understand that happening, so that's fine. You're not going to get penalized.
Okay.
Do you want me? Are there any other students while Jessie chews on her apple?
You're good.
Are you choking?
No, I was joking.
I was just choking. I'm like, why is no one getting up?
I was like, this is a horrible public health program.
Mallard is still.
I have, so Dr. Chesley gave me a contact for an IP person at Ballad, and I emailed her, no response, and I called her and left a message, but so I said like on the thing that I turned in, I was like I'll give them until Friday to reply, but then I have another contact, so can I just go ahead with Plan B?
Yeah.
And if she says like, oh hey, can I do 2 interviews?
Yes,
Okay.
you can do 2. You don't have to, like 1 is all you have to
Okay.
do. If you want to do 2,
Okay.
that's extra work. But there's probably 2 or 3 students a semester that want to do 2. Remember,
I want to do 2.
you want to do 2.
Yes, because I'm comparing to
Okay.
2 different.
The 2 systems.
Yeah,
that
like-
merge.
Because I'm comparing organizational change.
Mhm.
Like, so I want to know if the policies in these two different.
Yeah.
The change after.
And that's fine. Like the expectation is 1, right? The reason we wanted you to have a plan B is so that if things like that happen, we don't need to approve your plan B.
Okay.
The reason it's a homework assignment is because I know graduate students by now, not just you all, you're special and different than all the other students, except for in the fact that it's not an assessment, it doesn't have a deadline, you may just put it off until right before. And so this gives you a time frame that we want to see that you've started working on this, because this semester is like almost over. Like super almost over. So, if you are having trouble and running into roadblocks, let us know. We'll try to help you navigate that. I think almost every year, Mr. Youngblood either does some interviews or finds people in his organization to do interviews, or finds buddies that do them. So we've got contacts. We're a resource here for you guys. Online, on ground, no difference in helping you navigate that. Any other questions about the interviews? Take this opportunity to network, because your topic is something you picked that I hope is something of interest to you. And so you get a chance to talk to someone who's either doing the job you want, is an organization that you're interested in maybe interning in at some point, and you're asking them to talk about something that is of interest to them too. So you're not like, hey, I want a job from you. So you get an opportunity to interact with someone on a professional networking level that is low risk, but also allows you to show off kind of your intelligence and your passion and interest too. So take advantage of these opportunities. Okay. Anything to add, Mr. Youngblood, to the interviews? Okay. We're working on the first parts of your papers, but that doesn't mean you can't continue to work on the other sections while we're doing that, okay? All right. Okay, so today we're going to talk about special populations and health policy. These are we're getting to we have two more lectures? One more? I think it's just Mr. Youngblood left.
You just have one more quiz.
Sorry.
Yeah, that's one more. End with a bang. So this week, these are two topics and chapters that are really interesting to me. For those of you who've taken the intro course, or for the MPH, some of this, I'm going to try not to give too much information that was covered in that semester, so that'll be a little bit different. But when we talk about working in health services and public health administration, there are specific communities or populations that we consider special. And they're special because they typically, or all of these groups, the thing they have in common is that they have greater risk of poor health. And so these populations can be labeled or termed as underserved, medically disadvantaged, underprivileged, or underclass. So you hear a lot of terms, but really it's taking a disparate group of people or individuals. As you can see, these are the ones we're going to talk about today, and putting them together because they are at greater risk. And in public health, we want to lessen disparities in health so that these individuals, we can improve their health. So in public health, with the limited resources, we often find the vulnerable populations, and then we target interventions, activities towards them. In healthcare, these are populations that are more complex, more costly, need additional attention. So both public health and healthcare see the value of identifying and working to improve the health of these groups. Okay, this is hard to see, but this conceptual framework for vulnerability, what I think is really important is that you understand that there are convergence of vulnerable risks. So there are predisposing, enabling, and need characteristics, and you can see what they are. So their risks or their characteristics are at different levels. So the predisposing are those individual characteristics. So your race and ethnicity, your gender, your age, where you live. Enabling are things like homelessness, or your insurance or uninsured status. And your need characteristics are the things that are more directly related to your health. So your mental health, chronic illness or disability. And so all of these lead to vulnerability and are impacted by quality of care and access to care. And so you start with these contextual things. Some of these are characteristics that are amenable to change and others are not. And some that are amenable are very hard to change. But this is what you're working with in your vulnerability. And based on access to care and the quality of care, that can impact your health outcomes at the individual level and at the population, because a lot of what we look at is access to care and quality of care of systems and how they impact all people. So there's not a lot more that I'm going to talk about this, but this is like a systems way of looking at vulnerability. So now we're going to go into and talk about each one of these groups kind of separately. So often when we think of vulnerable populations or groups, we think of racial and ethnic minorities. And over a third of the U.S. population is minority. And this continues to grow. Our country is becoming more and more diverse. So African Americans or Black Americans make up about 13% of the population in the United States. They are more likely to be economically disadvantaged than whites. And they, almost on every health indicator, fall behind. Now, as a group, they've made progress, or there has been progress made in the past decades, but Black and African Americans have a shorter life expectancy than whites. And then when you stratify that by race, we'll see how that differs. But when we look at white men versus Black men, white men live longer. When we look at white women versus Black women, white women live longer. The largest, or the fastest growing and largest minority group in the United States are the Hispanic Americans. And they grow, that population is growing at a pace that is faster than other minority groups. They are a younger group overall. So because they're younger, there's also lower educational attainment. They have higher unemployment rates. And then the employment that individuals have, they have a higher percentage of individuals are more likely to have semi-skilled or non-professional occupations. And so we understand that those social determinants of health impact their overall health. So if their economic opportunities are less, that has an impact. And for Hispanic males, homicide is the 9th leading cause of death in this group. So that's pretty big. Why do you think?
For Hispanics,
Mm-hmm.
stress with work and finding financial stability.
Leads to homicides?
Oh, homicide. I thought I said. Well, I heard suicide. I heard
Homicides.
suicide. I'm sorry. That's why I was like trying to like connect it. I was like, my apologies.
Violence in the workplace.
My
Yeah, I
apologies.
was like, wow, really stressful
My-
workplaces.
My apologies. We all make mistakes.
That's okay. I speak softly.
I guess with like a lot of the minorities up there, they tend to live in urban areas, which tend to be a little bit more crime related.
Yeah, so maybe
So criminal activity and
criminal gang related
Right.
gangs, yeah, things like that. Also, if they're younger and they're men, yeah, so homicides, gun related violence, yeah. So Asian Americans, this is an interesting group. They are one of the fastest growing population segments in the United States. And of the other groups, Asian American is like a broad category that covers a lot of different groups of people. So Chinese, Asian Indian, Filipino. I mean, the group is so diverse, so it's hard to make kind of generalizations about all Asian Americans. You hear Asian Americans are X, Y, and Z, but individuals who are from different countries or parts of Asia, Southeast, versus others, they have different health outcomes. But one thing that is of note and interesting, I think, for Asian Americans is that they are more likely to be without contact with a health professional than whites. So they're less likely to seek health care. That's kind of a way to look at that. Any thoughts of why that might be? What would lead a minority to not seek?
Lack of insurance.
Possibly lack of insurance,
maybe a cultural
Yeah,
thing.
that language.
language and culture, yeah. It could be lack of insurance for maybe lower income Asian Americans. But I think a lot of it's cultural. And then we talk a lot about Eastern and Western medicine and differences. So that plays into culture as well. That might be part of it. Now, one of our most vulnerable groups are American Indians and Alaskan Natives. They make up a small percentage of our population, but they have some really bad, bad health outcomes. So compared to the general U.S. population, Native Americans have higher death rates to alcoholism, tuberculosis, diabetes, unintentional injuries, suicide, and homicides. And the rates of homicide in Native women and children is very high. And who's killing the women and children?
The bank.
Like
Yeah.
murder, suicide.
Just
Domestic.
domestic violence. It's really high. Yeah.
Can I say something about that?
Uh-huh.
So one of my brothers that's in the FBI for the last, until about 4 months ago, was living in South Dakota, and his primary job was working on reservations, being the federal contact for reservations. He says that it's an very, very, this is, okay, so let me give you some perspective. His career prior to the FBI was, he worked in Zone 1 in Atlanta, which is the most violent section of Atlanta, Georgia. And then after that, his first assignment with the FBI was undercover with the Russian mob. And he said that the issues that he encountered with the Native Americans on the reservations were some of the most violent things he'd ever seen, and it was always domestic related.
Yeah, it's a very
Is it, and I hate to adhere to stereotypes
Okay.
and stuff, but is it like alcohol related?
Which those are.
a lot of alcohol related. The suicide rates in male young men, Native populations, American Indians and Alaska Natives is really, really high too. So when we see alcoholism and suicides and overdose deaths, the term that's been used in the past probably 2 years that got coined is diseases of despair. So you see those in communities where there's a lot of hopelessness, and that we see that in poor rural white areas. But if you looked at Native populations out west, you'd see a lot of the same diseases of despair, hopelessness, things going on. So alcohol plays a major role in, I think, violence, regardless of race and ethnicity, right? So here are some statistics, a couple statistics, and then I have a couple slides that kind of lay out some of the data that was in the chapter that I thought was of not most interest, but I thought was interesting and I'd want to talk a little bit more about. Low birth weight is most common among Black Americans, and this is after you control for SES, so socioeconomic status, like any of the education, income. And so this is one of the differences that we see in a racial ethnic minority, that we cannot say it's driven by poverty. And it has been I have a slide on it, an issue that we just cannot seem to change the direction on for African Americans. And so why is low birth weight a problem? This is low birth weight, so it's babies. So why is that an issue? Yeah, there's a high correlation between low birth weight and infant mortality. And infant mortality is death within the first year of life. So we have babies who are born starting at a higher risk, and then infant mortality is also higher as a result of that in those populations. And maternal mortality also is higher in African Americans than whites as well. So the mother dying during birth. One of the things us whites have that we're like at the top is that we drink more alcohol compared to other groups. And that holds true for drinking during pregnancy as well. We also, I think, have a higher rate of smoking during pregnancy than others as well. Mammography, this is use for women 40 plus, is greatest among whites, lowest among Hispanics. We know that mammography is a really good tool to diagnosing early stage breast cancer. White women are more likely to get breast cancer, but compared to African Americans who have a lower incidence, African Americans, when they are diagnosed, it's at a later stage and they die from the cancer more often. So this one shows a little bit about access to prevention, or really secondary intervention. but there's also some cultural things that go into that as well. So here's this slide on low birth weight babies. So as you can see, everyone's kind of sitting around the same area except for blacks. I mean, this is really high. And what's disturbing to me about this slide in general is, I have one on life expectancy. We want the most current data in 2014 to be the highest, which is good. We want people living longer. We see that trend. But when you see low birth weight babies trend going higher since 1990 across pretty much every group except for blacks, that's a problem. Lots of countries are making great strides in lowering low birth weight babies and infant mortality. And so we see this trend going the wrong way. Why do you think? Any thoughts about what might be leading to this?
The opioid crisis.
Opioid.
Probably have an issue.
So, so when we think about low birth weight babies, where are they coming from? Where do babies come from? Not like the birds and the bees.
Well,
The mom, right?
Okay, that was like a really simple answer, but I was like,
Yeah. The health of women is really important. So focusing on women's health preconception, right? So if a woman starts out healthy, you want to start out healthy to help continue to stay healthy during pregnancy, because it is a vulnerable time, right? So, what are predictors of low birth weight?
Poor health.
Yeah, so the mom's health before conception, and then prenatal care.
Does teen pregnancy contribute to this? Because teen pregnancy is related also to low birth weight. So
Teen pregnancy, but we've seen a lowering of teen pregnancy since the 90s. So we have less teens getting pregnant now than we did in the 90s.
but in the black community, it's not
It's
That-
not that
that obvious.
Yeah.
So that might contribute. to
teen
this.
pregnancy in the black community, yeah.
I was gonna say obesity has definitely increased since 1990.
So obesity, so if you are an overweight or obese pregnant woman, is your baby big or baby little?
B. Yeah, you're at risk of having a bigger baby.
Yeah, because
Yeah.
of diabetes.
If you go to full term. So overweight and obese women are more likely to have early babies, so babies who are not full term. So even if they are a bigger baby, they're not as big. They came
They
early.
came out, yeah.
Yeah.
Okay, so
I
So
think
they're
it's a really
premature.
important correlation to make that just because you're obese doesn't mean that you're well nourished. You can be completely malnourished and
well, true.
Yeah. And so diabetes, gestational diabetes is higher correlated with big babies than just being obese, I think. Because that's when they're getting like a lot of, their insulin is not being regulated either, and it creates big babies. So women's health before she has a baby, access to prenatal care, age of the mom, all of that plays into it. And so, there's a lot of prevention that has to happen to make these changes, right? And it's complex, or we would see it getting better. But I think I say this every semester. The health of your women and children are, I think, the most basic indicator of your society. So if you take care of women and you take care of children, and if your women and children are healthy, that is a good indicator of a strong society.
Is it too like how women are having children later because they're getting education and like marrying later? Like that kind of is a factor too, like dealing with like age of a woman having a baby.
It might be. I don't know of any studies that have shown older women have
Like low birth weight.
small babies, low birth weight babies. Low birth weight and prematurity of the baby go together. So there are risks for women of advanced maternal age. That's what they call it. Old mamas.
A non-traditional.
Old mamas. But what's interesting is as more women,
Advanced is 35.
that is the current cutoff.
Yeah.
But as more and more women have children into their late 30s and even into their early 40s, we're seeing that the trends are not. You can have lots of healthy babies at advanced maternal age. The curve used to be a little bit different, so more women had babies. The top of your curve was in your early 20s. It's now getting in your later 20s, or I think it's even 30. So that changes your curve, your bell curve, right? So we have more women who are advanced maternal age that are having perfectly healthy children. There are a lot of more risks at that age, yes.
Is low birth weight under 6 pounds?
Who can do the conversion of 2,500
Oh, it's right
grams?
there.
I think it's
That's
Five.
2.5 kg.
Oh, 5.5 pounds.
That's less than 2.5 kg. Okay.
Let's see, grams.
That's about
pounds.
6
You
pounds
said
actually.
it.
5.5 pounds.
Mhm. And the average
Oh wow.
to be considered a large baby, I think is 8 pounds 2 ounces. If you're above that, that's a big baby.
So
What
the
do you
average is like
How many of you-
This is my spectrum of my children. Like, my third child was like 8, 12. My fourth was 5, 14. So it was like
all over the place.
8 pounds, that's an American baby.
Yeah. Yeah, we have bigger babies here.
them corn-fed babies. That's what I have around these parts.
Anything else? Any other thoughts on this? I find, I'm maternal child health researcher, so I find that very interesting. So this is also interesting because when you look at the alcohol consumption by persons 18 years of age and older, so not even of legal age, but non-teen, not 18 and older, we see everyone but one group increasing their alcohol consumption.
Really? That's interesting.
Interesting.
Yeah, I mean, Americans are drinking more than they used to.
And millennials are changing the way wine is being sold.
Yeah, I mean, the wine is very popular. There's a lot more
Syrup.
acceptance of drinking socially, I think. Women are drinking at much higher rates than they used to as well. I think that drives up a lot of this. But across the board, everyone except the Native, Alaska Native and American Indian group is increasing. Now, even though their rates are going down, they're still the third highest. So, it's good that they're going down, but it's in 1997 they were the highest drinking group.
Is it?
But whites drink more than other races. But
I was just gonna say, could it be because of all the well, I'm not sure how many or how often it's done, but maybe measures with, alcoholism being a problem with the Native American population, like measures to reduce that.
Yeah,
I guess
that's what you would.
why.
That's what you'd hope, right? That we've seen this as a problem, and we have in public health, and there's been a lot of work to impact that in that community. But yeah, whites and white women drink a lot more than others, and then the next are Hispanics. You see that rising as well. So, are you gonna say something?
All them hipsters.
It's all the millennials. Okay, so these going up, we're like, this is not that great because we know this looks at overall alcohol consumption. It's not looking at binge drinking or alcoholism, but just overall drinking, of consumption of alcohol. Doesn't say what kind of alcohol. Okay, so this is what we want to see. Across life expectancy from the 70s to 2014 in our white males, white females, black males. Black females is all going up, right? And in 2016 and 17, this data look a little bit different for whites. Okay, so whites, if you look at it combined, everybody's life expectancy was going up, but we're kind of plateauing and going down in the white population right now. Why? What's driving?
Chronic diseases, obesity, physical inactivity,
Drinking.
drinking.
Remember those 3 diseases of despair I said?
Oh, suicide.
Suicide, cirrhosis of the liver, so drinking related, and unintentional injury, overdose deaths. So I mean, the opioid epidemic is literally changing the curve of life expectancy.
At the conference in
Or-
Greenville, if so, they were saying that the kids being born right now is, I don't know if it's the first generation, but like it's a new thing that they're not gonna have as long as lifespan as their parents.
Yeah, so that's been happening for probably about a decade.
Why?
Is
But
that
so
weird?
why?
So it's old.
No, it's not old.
So
It's
that's
new.
So that's speaking up.
But we're hoping that it's going to continue. Like we want to change that, and a lot of it has to do with obesity. They think a lot of that has to do with chronic diseases. So children getting chronic illness earlier shortens your life. So.
Right.
So we see the trends going the right direction, but who lives longer, and this is something that you guys probably know from last, who lives longer, men or women?
Women.
Mm-hmm. So white women live the longest, black women live the second longest, but they live a shorter life than their white counterparts. So when you stratify, they're doing better than men, but when you compare them to same gender, different race, they're not doing as well. But the magnitude of the difference between white women and black women, is it greater or smaller than black men and white men? Smaller. Yeah. There's a bigger gap in life expectancy in white males and black males compared to white males. And so
Living forever.
what typically what did you say?
She's like, I'm sorry about it.
She said sorry.
I don't know what she's talking about.
So,
Got me, it's not catching.
So why do you think men live shorter lives than women?
Violence.
Risk behaviors. We lose more young men than we lose women for really dumb things, right? Car accidents, lots of unintentional injuries. Like, just go to YouTube
Oh my god, I was
and
gonna
you will
say
see
that.
just the dumb things young men do.
I'm Johnny Knoxville, welcome to Jack.
The guy was doing the skating thing and kept on falling and doing it again and again.
Yeah, so again, these are really important metrics. None of these are written in stone, right?
Yeah.
None of this kind of more like depressing information that I'm providing right now is, written in stone, and that's why we talk about and identify the disparities, the special populations in our classroom, and public health in general, in hospital population health. That's the focus, is so that we can identify individuals at highest risk and do something about it, right? It's not just so that we leave on a beautiful Thursday evening feeling really bad. Okay, so moving from racial and ethnic minorities to the uninsured. And so what we know about the uninsured is that they're typically less educated and are poorer or more impoverished. That has a lot of these are so interrelated. Lower education has an impact on your employment opportunities. So there's a lot of working part-time jobs or employed by smaller firms. If you're working a part-time job, you don't have as much money, so you're poor, right? So they're so interrelated when we talk about education, health, and economic development or employment. And typically uninsured are younger. So the largest group of uninsured individuals in the United States are Hispanic residents. At about 20% of Hispanic residents are uninsured. The next largest group are Blacks at about 12%, then Asian Americans, and then at about 9%, and 8% for whites. And this was in 2014. So why do you think more uninsured people are comprised of young workers?
You don't make as much money to be able to afford it.
Yeah, you don't make as much money, and then
Just enough and not to qualify for government aid.
yeah, so you're in that kind of donut hole, or in that gap of you don't make enough or you make too much to qualify for government assistance, and if you don't have small children and you have low income and you're in a non-Medicaid state, it really doesn't matter, right? If you're a single male in a non-expansion state, your income doesn't matter, you won't qualify. You often don't make enough money to even be able to find the money in your budget for health insurance on the marketplace. And there's people that fall into this kind of middle area who don't qualify for subsidies but don't qualify for government assistance. And also, young people can make intelligent decisions about, do I want to pay the premium every month? Or since I haven't had a cold in 3 years, do I risk it? I'm young, I'm healthy, I work out, So young people are less likely to seek out insurance. And so some of the things that the Affordable Care Act tried to do was to incentivize, but the penalties are lower than premiums that someone might have to pay throughout the year. So you could look at the math and think, I just won't get it. So uninsured is important, but there's a whole other group that I really appreciated Bo talking about on Wednesday, our Breakfast with the Experts speaker, about underinsured, right? So some people do have insurance, but they still cannot afford to use it because their deductible's too high. They can't get off of work, those things. So there's different things that go into play when we talk about uninsured is a major issue, but even underinsured are vulnerable of not seeking care when they need it. Okay, so approximately 74 million children. There were approximately 74 million children younger than 18 living in the United States in 2015. So that's about a quarter of our population is under 18. And about 21% of those children live in families below the poverty threshold. So 15.5% of our children live below the poverty line. Our children are more diverse, if you were to look at the ethnic and racial breakdown of children, than the overall population. Why? So
interracial marriage and family. Is that what you're getting?
So if our children are more diverse than the overall population in the United States, what does that mean? How do you get
interracial? Wait, what are you talking? Is that what you mean?
Minorities are having more children than whites.
Yeah.
Oh.
So the family sizes are.
Me and Adrian have a birthday.
Ooh. So if our children are more diverse, that means our minority populations are having more children born than white people are having born. Okay.
So stuck in that interracial.
There are some
I think just
interracial.
meant like genetically, just like they're all.
I mean, I love it.
like they're so unique.
Darn biology.
Yeah, nice.
So, I mean, to really look at this, a quarter of the children are Hispanic in the United States.
Oh, wow.
So when we talk about what our country's gonna look like, seeing what our children look like will show the change in our minority status as a country. And that's really interesting because in 1980, less than 9% of our children were Hispanic. 1980. So around the time when Mr. Youngblood and I were children, only about 9% of kids were Hispanic. Now, a quarter of them are. So it's really, we're seeing a lot of changes in our country. And so we're seeing, and the statistic that Mallory mentioned was about children born now having shorter lives than this generation. So the generation, it's right, children being born now. And we're seeing children who have higher BMIs. They have different kinds of morbidities related to drug and alcohol abuse, family and neighborhood violence, a lot of emotional disorders, learning problems. There's a lot of things that are leading to that statistic. And there are a couple things that make children more vulnerable. So we talk about developmentally. There's a lot that happens in the first years of your life, right? You go from like this little itty bitty thing to like a person, right? Like an adolescent. It's a lot of change, physical and emotional, that characterize. And when that physical and emotional change is happening, if you're having adverse events happen during that time, that impacts the life of that individual. Also, kids don't have a lot of power. They don't get to make a lot of decisions about what they eat, where they live, their access to health care. So they're vulnerable based on their dependency as well. And so there's a lot of really good public health interventions that happen in early childhood that can help create resilience, provide access to healthy foods in the school setting, early childhood literacy programs, all the things that can help set up children to be healthy and have both emotional and physical health. Okay, so women, like we looked earlier, live longer than men. So yay, we live longer. But they suffer greater morbidity and have poorer health outcomes. So their mortality and morbidity, right? So they're living longer, but their morbidity or illness is greater. So we see heart disease and stroke account for a higher percentage of death in women than men. And women are more likely to die of a heart attack within a year of a heart attack than men. Like 42% versus 24. That's percent of women. It's pretty incredible. And women make up slightly more than 50% of the population. About 50.8% of the population in the United States. And so I'm trying to see if there's anything I didn't say. We're seeing higher rates of obesity and overweight and increases in obesity in non-Hispanic, Black, and Mexican American women. Those are things that are creating a lot of this disparity. So when our largest two minorities have higher rates of obesity and being overweight and obese, that can lead to, those are risk factors for heart attacks, and that again can increase that. Two things that are in our favor compared to men is that women are more, most women ages 19 to 64 have some form of health insurance coverage at a greater rate than men. Why do you think women have more health insurance than men?
You're more careful.
Careful?
Yeah. Because we take more care with, oh my God, just in case something was to happen.
Yeah.
I'm not going to ride that bike, then I'm going to also buy insurance.
I'm going to buy insurance. So that it might be something about
might be a stretch.
risk taking versus men.
We utilize more preventative care than
We do utilize more preventative care, but does that lead us to have more insurance? Is that on the causal pathway?
maybe not.
Maybe
Oh,
not.
yeah, another thing is, you
Children.
have children, yeah.
When you have children, so any woman who has a child or is pregnant will have health insurance in the United States. Okay. And then the 6 months after the baby's born. So that plays a part of that too. So, and then again in Medicaid, for states that did not expand, women and their children can get Medicaid or are eligible if they meet the income levels too. So in those 19 or so states that did not expand, women have more access at a low income than men. And then when you have children, that plays a role in that too. So, and then we binge drink less than men. So the rates of women drinking is going up. Men binge drink more than women, but we're seeing increases in women's alcohol consumption and binge drinking in particular in women than men, or over time. Men still do it more. Okay. Women account for approximately half of the HIV/AIDS cases worldwide. They're also more likely to be depressed than men, and then have a greater risk of Alzheimer's than men. So across the life course, we have some serious disparities. But like I think it was Mallory said, women are the principal users of healthcare, both for themselves and as the family care coordinator. So that kind of gets at what Aretti's saying, like they're risk averse, they seek care for themselves and their families. Until age 65 and older, women have a higher utilization rate than men. What happens at 65? Medicaid, right? And retire. Who's retiring at 65? I'm gonna work forever. So you can get Medicaid. So things that can impact women, women face a distinct disadvantage in obtaining employer-based insurance, in part because they're more likely to have part-time jobs, they receive lower wages, and women have interruptions in their work histories. And so we see women who, after they have a child, not going back into the workforce for a couple years. Why is that?
It might be cheaper to depend on one income than pay for daycare.
Yeah. Childcare is really expensive in the United States. So families make decisions, especially once you add a couple children in. Guess what? They don't give you discounts because you have more kids. So you have to pay the same rate. They may give you like a kickoff of $20 or something every month. It's not enough to make a difference, right? So you add one child, even in the United States, in certain areas, it just might not be financially feasible. So that can impact access to employer-based health insurance. And that's why we see, I think, that women are twice as likely to be covered under Medicaid because of programs like Families with Dependent Children. Because of that case, that if they don't have access through employer insurance, it's likely that if you can qualify for Medicaid, then it does not make sense for you to go back into the workforce. Okay, so rural health, we've talked a lot about rural health in this course, but rural citizens, access to health care may be affected by poverty, long distance to service providers, the actual topography or the geography of where they live, lack of transportation, and being uninsured. Across all races and ethnicities, rural residents have lower levels of insurance coverage, we know there are shortages in providers, including obstetricians, pediatricians, dentists, nurses, you name it. And then we know all about the rural health care hospital system. So here are a couple different measures to improve rural health care. The National Health Service Corps. How many of you guys read about that? You guys have read about this, and many of you talked about this in your homework around rural health, rural maldistribution of physicians, right? So this was created to target practitioners who for loan repayment and scholarships, and has been very successful in placing different providers in medically underserved areas. To be considered a health profession shortage area, it's based upon criteria related to geographic areas, population groups, and medical facilities. So the population to full-time equivalency of physicians ratio is at least 3,500 to 1. So that's a big difference. Okay. But it's can't be greater than 3,000 to 1. So it's within that range. And so this designation can be either urban or rural. So it's not specific to rurality, population groups, or other things. Medically underserved areas were developed, an index of underservice was developed to target community health centers and rural health clinic programs. So it comprises of 4 different indices. Percentage of population below poverty income level, your population age 65 and older, your infant mortality rate, and then your primary care physician per 1,000 population. So based on those factors, an area can be designated as medically underserved. Okay, so community and migrant health centers, these provide services to low-income populations by establishing sliding pay scale based on income. And so minorities are the highest users of these services. So when we think about migrant workers, are farm workers who travel long distance from their primary residency, or often lack a primary residency, either due to seasonal crop changes or work availability. So these are individuals who provide a major important service to the United States, working in farms, but because of the way that work is, they move around, right? They're migrant workers, they move around. So to address the growing needs of these populations, services have been provided to migrant workers and their families through state programs and through the HRSA's Migrant Health Program. Some of the challenges is that they're hard to attract physicians to, but they offer mostly primary and preventative care. We talked a little bit about this when we talked about outpatient care. And then the Rural Health Clinics Act was created due to the concerns around isolated rural communities. And so it's a reimbursement mechanism that creates financial viability and availability to receive Medicare and Medicaid reimbursement. And so it permits PAs, so physician assistants and nurse practitioners, and certified nurse midwives to practice without direct supervision from physicians. So it's typically at a state level, the number of physicians that can supervise PAs and nurse practitioners, and that can be a barrier because they have to typically be within a 50-mile radius of the physician, and the physician can only supervise a certain number. So this releases them these different mid-level providers. Okay, so we will take a little break and then come back and finish this. You guys are looking a little long in the tooth, so come back in 5 minutes. Through. Okay, so the next group of people we're going to talk about are homeless individuals. About 3.5 million people in the United States live without a home. There are multifaceted problem related to personal, social, and economic factors. Homeless adults and children have high prevalence of untreated, acute, and chronic medical, mental health, and substance abuse problems. They're at greater risk of assault and victimization, and exposure to harsh weather. They're more men than women, single men than women, but quite a large percent of families. So of the homeless, there 36 are over a third, or about a third are families. Yeah, that's a lot of kids without a home. So there's a lot of reasons for barriers to healthcare. There can be individual or system level. So individual barriers are competing needs. So if you don't have a home, you probably have other needs that are greater than healthcare, right, in your hierarchy. Mental illness and substance dependence have a lot to do with that as well.
So, are those percentages?
They're not mutually exclusive.
Okay, because I was like, those don't add up.
No, because the children under 18 also often reside in families, right?
Oh, okay. That makes sense.
The men and women, single men and single women, those are mutually exclusive groups, but the children and the families are not. Okay. And so these individuals are also, so the system level is factors that relate to barriers are availability, cost, and convenience. So there is outreach to get care, healthcare, to shelters, hotels, soup lines, parks, and bus stations. So you do see outreach done there. And the Salvation Army is one of the resources that provides social rehab, social support, food, and housing to homeless individuals. And then there's a push for mental health. And then what's a large those single men, who do you think makes up a good portion of the single men who are homeless? Veterans. Yeah, so there's a lot of work to help veterans. There's a lot of interesting novel things that are happening with homeless populations in urban areas, and that's supported by some federal efforts, but also foundations like Robert Wood Johnson Foundation that are trying to, there's a movement and there's data that support getting people into homes first. So getting them in a home and then working on getting them a job instead of, let's get you a job, save up your money and get you a home.
I know in Seattle, so in Seattle they have a huge homeless population, and also Seattle is a big port, and right now they're actually using those like big things they put on the 18-wheelers that like comes over. They're using that for homes for homeless people. So it's pretty cool. So you have like little cities up.
Cargo containers.
Yeah. And so there's a whole neighborhood now in kind of like the stadium area of Seattle, and it's just all of those. It's actually pretty cool.
Isn't there some city here in the U.S. that also did the mini homes and made a bunch of mini homes?
Yeah.
I think that's in Arizona.
Yeah, I don't know what city.
That's a Winnie City College.
Yeah.
Those containers are amazing.
Yeah,
They're
it's
really-
kind of hip to live in those now
Yeah.
too. Like I think
Honest.
millennials, not just homeless, like
I've
you
seen
know,
I've seen a lot of fancy modern houses that
look
are
like
just-
containers.
they are containers
Yeah.
and they're like,
Yeah, I
you
mean,
can't afford them.
Well, it's-
Yeah.
it's-
I follow this architecture guy on Instagram. He does amazing work.
with the container.
With the and there's even outdoor housing where there's actually like no roof. Like you're paying a lot of money to live
With no
in the
roof.
wild. Like that is
And also there's a sustainability factor because there's no, sometimes they don't reuse those.
Yeah.
So
So there are some, and the evidence show that getting someone in a home, in a residence first, helps them keep from going back to being homeless. And homeless does not just mean like living on the streets. There's a lot of people who stay with different family members, like couch surf, or they just have lost the ability to pay rent every month. So they bounce from family member to family member, or friends, and then sometimes when they outstay their welcome, that's when they end up in shelters or other places. But there's a high incidence of substance abuse and mental illness in the populations that are homeless. So there's a lot, we could do a whole lecture on mental health, but we don't have time for that in this course. But mental disorders are common psychiatric illnesses affecting adults and present serious public health problems in the United States. 1 in 5 Americans has a mental disorder in any given year. And we have disparities in availability and access to mental health services. Mental health has typically or traditionally not been covered under the same way as physical health insurance. So a lot of the resources are available for those who are very, very poor, so people in Medicaid, or those who have the financial ability to pay out of pocket. So there's also lots of issues around stigma and fear and hopelessness. When we think about depression, typically by the time someone is very, very depressed or clinically depressed, they don't have they're so hopeless they don't have the desire to seek out services as well. this is changing. So, like I said, Medicaid is the single largest payer. More private providers are starting to take insurance as well and joining managed care. So as we know, chronic disease accounts for 75% of the total medical expenditures. And that's just a broad term for a disease or injury with long-term symptoms of 3 or more months. And a disability is a person's short-term or long-term limitation or inability to perform tasks that were previously done unaided. And can be characterized as mental, physical, or social. Physical disabilities are things that individuals like Areti look at for qualities. Is that what dailies?
Quality of life.
Or dailies.
Activities of daily living.
Activities of daily living, yeah. So, what are some risk factors for HIV and AIDS? So, in 1982, a disease was officially named acquired immunodeficiency syndrome, or AIDS. And AIDS is caused by human immunodeficiency virus, or HIV. It's the 6th leading cause of death among people aged 25 to 44. About 400,000, never mind, I'm not going to even try to say the number. For whatever reason, I can't get it out. Almost 500,000 people are living with AIDS in the United States. So what are some risk factors for HIV/AIDS?
Drug users? Or people that share drug use?
Yeah, so it depends on the type of drug. Injection drug users.
Risky sexual behavior.
And what types of sexual behavior?
Men who sleep with men.
Men who have sex with men, yeah. MSM is like a high one. And then male to female sexual contact. Not so much now because of the screenings that we now do for our blood, but blood transfusions were at the initially one of the risk factors. And then transmission from mom to baby during pregnancy, delivery, and possibly through breastfeeding. But you get screened at least a handful of times for HIV and AIDS when you're pregnant because it is very risky. So the cost is very expensive. We are seeing now through the advancements in the drugs available that people are living a longer life, but those drugs are not cheap. So it's gone from a acute infectious disease to a chronic illness for people. And there are waiver programs that allow coverage through Medicaid. And the Ryan White Care Act of 1990 gives federal monies to help public health. And so this is a formulary grant from the federal government. So based on the incidence and prevalence of HIV and AIDS in your community, you get more money for this. HIV testing is cheap, and most states offer anonymous HIV testing. All states offer confidential testing, and there are now rapid HIV tests. So there have been work to identify those high-risk populations, either injection drug users, men who have sex with men, or certain populations and communities that have high incidence. So they're typically urban areas. Though we've had outbreaks of HIV in rural populations due to injection drug use. And it's very scary because if you have one user in a small community that has HIV, it spreads very quickly if you're sharing needles. And we saw that in Indiana. In our area, due to the high prevalence and incidence of Hep C, is considered a likely next community. So
Because I oh, bless you. Bless you.
Thank you.
Because I have problem of Pepsi.
Hep C, hepatitis C.
Oh,
Peps.
I was like, Pepsi.
Of Hep C.
I was like, what did they ever do to you?
We should all drink Coca-Cola. No, hepatitis C. So
We
there's
don't like
a lot of comorbidity, and it's transmitted in a similar way. So if you have a population that already has a high injection drug using population that has high incidence of hepatitis C, they are at really high risk of having a outbreak of HIV. So most of the federal spending for HIV is on care and treatment. We spend, the next largest part is on global initiatives, followed by cash assistance and research. But what's the sad part of this?
Prevention is very small.
Very small, right? This is the public health practitioner, and you should just cry a small tear because we spend so much on care and treatment, which is so costly compared to prevention, which could be clean needles for injection drug users, could be protection, and then there is some prophylactic medicine for individuals who are practicing high risk sexual behaviors. But those drugs are kind of nasty too, even from a prophylactic. Like the side effects can be pretty nasty. So
I heard that the side effects don't last that much. Like you can have the side effects
from the medicine.
From the medicine, but if you continue using it, it kind of
It's. I still think it's better to use the medicine than get HIV. Okay, so we're moving from any questions on special populations? Which one?
The one you're about to click on.
The capital colors.
Okay, so we're gonna watch two of these for the online students. It might not play for you because of the way the technology works. But they're available on the D2L site. So
If only.
Sing along.
most of you have seen this, right? Does Bermuda show this?
Chesley being underground.
Just about.
I thought the executive order one would be interesting and humorous and timely because we have seen all presidents use executive orders. The previous president and the current president have been using them more for like bigger things. And so we saw with, so that was talking about DACA, and we saw the executive order created DACA, and we've seen executive order go into place, be signed to end DACA. And we also are seeing executive orders happening around healthcare. So lessening of some of the regulations around the Affordable Care Act. So part of the reason we see more executive orders is due to the previous process of the bill going through the House and making it out of committee and making it going to the Senate. That process is not working very well for a lot of different reasons. So presidents are using the executive order, but like that bill said, that they're going to take them to court. There is judicial. Things are going through the judicial branch to stop those. So I thought we'd start on a little fun little piece to break up the lecture. So we're going to talk about health policy. I know many of you, the MPH students, you take a whole course on this. The certificate students, you could take health policy as an elective. And we also have a public health law course that you guys take. So this will just be one lecture that will not be able to cover everything. But health policy, we have public policies that are the authoritative decisions made in the legislative, executive, or judicial branches of government. And health policy are specifically aggregate principles, stated or unstated, that characterize the distribution of resources, services, and political influences. But health policy, the big thing is it impacts the health of the population. So the danger is that policy making often becomes highly politicized and is held hostage to ideologies of the political party that happens to be in power at the given time. So the party in power also exerts considerable peer pressure on its own members to support policies along party lines. And I think that's why we saw President Obama use the executive order more, because he was the party in power for the majority of his tenure as president was not his party. So he didn't have alignment, and so the things that were his priorities were not getting through, and so he used the executive order. We're seeing the current president use them to get things that, even though his party is in charge, that peer pressure seems to not be working within the party to get things done. And then there's not a supermajority, and so a lot goes into that. But the danger is when policy is so politicized, as we see it now, that it kind of gets stagnant. So there's different forms of health policy. And so these include reforms on medical education, the 1965 enactment of Medicare and Medicaid, that's a health policy. Federal funding for family planning clinics, our Title X funding. We learned this week about a merger of 2 hospitals that had to go through a lot to show, to help ensure that they didn't violate antitrust laws. Licensing of physicians, sanitation standards, and restaurants, and then like broad banning, smoking bannings and things like that. So there's a variety of things that fall under health policies. And so health policies may be used as regulatory tools or allocative tools, and the difference between that. So regulatory tools call on the government to prescribe and control the behavior of particular target group by monitoring monitoring the group and imposing sanctions if they fail to comply. And so some examples of regulatory tools are drug safety, so ensuring that the drugs, and that's like from the FDA perspective, drug safety, air pollution control, and then licensure and certification of facilities. So these are regulations, regulatory. Allocative tools involve direct provision of income, services, or goods to certain groups and individuals. So they're allocating something. And so some examples of allocative tools are funding of medical research and the development of medical personnel. So the funding for residencies is an allocative tool. So allocative tools are subdivided into distributive or redistributive. Distributive are, again, there's like funding of research and development and construction of facilities, so it's distributing. Redistributive, what is that? So if you redistribute, so
Get the money back out.
you take money or power from one group and give it to another.
As in putting taxes on somebody and then spreading the revenue amongst the population.
Yeah, so
Tobacco, like the tobacco companies
yeah, so it's tobacco,
and the
super funds.
Yeah.
Yeah, so if what are some other? Can anyone think of any other redistributive?
Weed. Like in California, not California, Colorado, it's taxed so much, and then they are expected to have, I remember, like billions of dollars, and they're putting that towards their education in Colorado,
Yeah.
in the state.
Yeah, we see taxes, vice taxes being used towards education and things like that. So, lottery is one, but so it's taking money or power, but typically it's like a super fund, the tobacco resettlement funds, and those. Okay, so there are a lot of features and characteristics of health policy that make it so interesting. And we're going to go through these. So it's fragmented, it's incremental and piecemeal in reform. It's pluralistic, which just means there's a lot of interest groups. Our decentralization role of the states, what we'll talk about. The impact of the president pushing bills down the stairs. No, just kidding. And, looking at it from that focus. So when we think about government spending on healthcare fills the private sector gaps. So where the private sector has cannot meet the need or won't due to competing interests, then the government spending on healthcare fills in. So some of the interventions that kind of are exemplary of that are environmental protection. So the requirements of industry to take into account its impact on the environment, because people would say the government doesn't trust industry to do it on their own, but they have different competing interests. Privately held company, the most important thing to them and their shareholders is money, right? It's revenue. And sometimes that can get in the way of protection of the environment or maybe protection of employers and workforce. Preventative services, communicable disease control, and others listed here. So the most cited problems associated with government involvement in healthcare are things that if you were to talk to any healthcare administrator, they would probably list most of these, right? There's a lot of inflexibility. So the bureaucracy was created, and you can talk to different systems and hospitals and say, this one size fits all doesn't work for us. We feel like we are an exception because of X, Y, and Z. The idea that regulation has gotten excessive, too much government influence, lots of paperwork, red tape, arbitrary and often conflicting directives, inconsistency and enforcement. All of these, the bureaucracy, the regulation, the red tape, the paperwork, leads to escalating costs. There's fraud and abuse, inadequate reimbursement schedules. So we've seen, and many of you have discussed, that reimbursements are going down from the federal level, and there's not a lot healthcare can do about it. Denial of claims. I think Mr. Youngle's talked a lot about how you have to have really good coders and make sure you're doing like everything right, because that retrospective case review, you can get claims denied if you miss something. This all leads to dissatisfaction with both the consumer and provider. And then something that we're hearing a lot, we've heard a lot, and it's very vocal from the federal government, from those in power now, is that government programs tend to promote welfare dependence rather than a desire for employment. And I mean, this is a real true issue, is that there are people who, if they do get employment, they lose their benefits, but their employment doesn't supplement their income enough for them to be able to make up that welfare difference. So they may get a certain amount of money in food benefits, but if they get a job, their income is not meet that same number that they can put into their budget for food. So there's not an incentive to get that job. Yes?
What does red tape exactly mean?
Red tape? Is that like that's probably like a Western thing. What would you say red tape?
It's just like a very deep level of bureaucracy,
Yeah.
paperwork, just a lot of different methods that you have to get through in order to get to the objective.
Yeah. And I think it falls into like a king used to put a red ribbon around certain policies. It's like this long, silly way of saying pretty much excessive regulation, paperwork, everything requires a lot more than it needs to get to what you want your outcome to be, like Mr. Youngblood said. Any other things on here that? Okay. So when we think about this pluralistic piece and interest groups, so all three branches of government, legislative, executive, and judicial, are suppliers of policy. And so presidents, governors, and other high-level public officials propose policies in the form of proposed legislation and push legislators to enact their preferred policies. And then the courts can interpret an ambiguous statute. They can establish judicial precedents or interpret the Constitution and make policies. So we see this as presidents often lay out their budget, right? So we saw a budget coming out of the executive branch, and that's like the president's wish list, right? That's what he or she sees as what they are proposing, their vision. And then they put pressure on the legislative branch. They typically can put more pressure on their party to try to push their proposed budget. So the first budget we saw, for example, from the president, zeroed out the Appalachian Regional Commission. So that would say that that agency, which is a very small one, would have no budget. And the president said, this is what I want. I don't think he was against ARC, but he wanted to cut a lot out of the budget. So he was cutting things where he felt that he could. Well, the legislators, especially those who have counties that are part of Appalachia, would never go for something like that. So you see that the final budget that was passed by the House and the Senate had a lot of things that the president did not want. But ultimately, they're the ones who hold the purse strings. Now, if the president has an executive order that interest groups feel is unconstitutional, then that goes through the courts. And there can be court orders to stop that from going into place. Any law can be challenged in the courts as well, not just executive orders, which come from the president. So you can see how each one of the different branches has a role in policy development. In addition to that kind of pluralistic, there are well-organized interest groups that can be the most demanding of policies. And interest groups, well-organized, and what else is important for an interest group to be? Not only well-organized, but well-funded, yeah. Right?
And then a large number of
I know, I was like, wait, what's the number?
Having a large number of people
especially
helps.
diverse electoral groups, I guess.
Yeah, so we're seeing more well-organized interest groups. What was one that was in the news a couple of weeks ago that marched in Washington?
Oh
and
yeah,
marched
March for Life.
March for Life, yeah. So that was getting at what Areti was saying, like a large organized group of loud, big individuals. But often the interest groups are those that are working behind the scenes and have a lot of money. And so to overcome that, you get a group of really dynamic, invested individuals that will go out and call their legislators, march, do whatever they can to get their voices heard. So some of the well-organized interest groups around healthcare, what are some that you can think of?
American Medical Association.
American Medical Association.
The AARP.
Yes. The American Association of Retired Persons. That is why we continue to not see any major cuts in Medicare. Yeah, they are a good, well organized interest group. The American Hospital Association, and then Pharmaceutical Researchers and Manufacturers of America. So they play a big role, and then businesses are becoming more and more bigger interest groups as they start to use lobbying and things to get to influence as well. So the way our system is set up is through a federalistic system where the states are given all the rights that are not in the Constitution. So the Constitution is the document that gives power to the federal government. And any power that is not explicitly listed in the Constitution is given to the states. That's states' rights, that's federalism, that's how we've been set up. That is a very important part of the way our government runs. And so that leads each individual state to have a role, and they choose how to govern and provide care and all kinds of different things based on their own rights. What they've decided is what they want to do for the people in their state. And states believe, and I think it makes perfect sense, that they know the people that reside within their borders better than the federal government, and they should have power to do things, to enact laws, provide services and funding for certain things. So they provide support for care and treatment of poor and chronically disabled. So the reason that the Medicaid expansion was deemed unconstitutional by the Supreme Court was that the states went up and said, it's our money too. Like Medicaid is both state and federally funded, so you have no right, federal government, to tell us how to spend our money. And the court said, yeah, you're right. And so they decide how they want to use the money to take care of poor and chronically disabled. Oversight of medical healthcare practitioners and facilities, those licensures and the facilities, that's the state that comes to knocking on the doors at Quillen Rehab, right? And you've worked in multiple states. Are there a lot of differences across states, or do they stay?
Yeah, Arkansas is very, very heavily regulated on the state side. They have a lot of, like, there's a lot of hoops to jump through.
Mm-hmm.
And Tennessee's not as bad. Georgia, probably middle of the road between the two. And I think it's just the experiences each state has had. And so when you have different types of events occur, they develop their own policy based on, on what to fix. And, you know, we don't have a lot of the problems they have in Little Rock here in Johnson City, for example.
Yeah. So there's the oversight for the healthcare practitioners and facilities, and that is at the state level. Regulation of healthcare costs and insurance carriers is also state-based. Some of the more innovative ideas coming from the federal government is to allow insurance to be over state lines, and part of the reason they haven't been is because of the way it's been set up at the state level. And then authorization of local government health services. So we talk in HSMP 5500 about home rule authority. So certain states give the authority around health services to the local government, because local government is afforded no rights in this federalism system unless the states say, we believe, and it's just taking that level of another layer down, that you at the local level have the most understanding of this community, and so we're going to give you home rule authority to around health services. Okay, so the president has a lot of impact on health care. So presidents have important opportunities to influence congressional outcomes through their efforts to bring compromise, to engage in political maneuvering, and to take advantage of economic and political situations. Even under some of the most auspicious political circumstances, presidents are often hampered from getting their agendas fully adopted by Congress. We have seen this play out very publicly with both the most current presidents. But some of the impacts that they've had on healthcare, Lyndon B. Johnson was the president who passed Medicare and Medicaid. Harry Truman passed the Hill-Burton Hospital Construction Act. We talked about managed care last week, and President Richard Nixon passed the Health Maintenance Organization, the federal support for it, and enacted the National Health Planning and Resource Development Act. President Bill Clinton tried to get to pass a comprehensive health care act and was unable to. But President Obama was able to sign the Affordable Care Act into 2010. And then as soon as a president from another party got into power, what happened? An executive order, right? To repeal parts of the Affordable Care Act.
And slip stuff into that new budget bill.
Oh, the tax bill was the first one, right?
That's
So yeah, that also happens. Is we haven't seen a full repeal of the Affordable Care Act. We've seen what some might call a dismantling or in stabilizing of the Affordable Care Act.
I did for Dr. Ramoda's class. We have to do a current affair. Not to take up more of your time, but I saw where that new tax bill that. This is what I did my current affair on, that 20 states sued the federal government because with that new tax bill they slipped in there that basically did away with the individual and the employer mandates.
Mhm.
So the basis, like foundation of that, so they sued to have dismantled since there's no divisibility clause, if that's the correct word. So like if this part's done, then it still is functioning. So since those bases have been taken away, they're trying to get rid of it and just say we don't
want
there's no reason to have it.
have the Affordable Care Act, to say that, and so the individual and the employer mandate, are those really popular parts of the Affordable Care Act? No, you guys talked about that. But are they necessary?
Yes,
Why are they necessary?
because you need enough elderly people in the pool to reduce the cost. Then, if without that part of the AC, everything crumbled.
Yeah, so they're the parts, the unpopular parts are the parts that are funding the popular parts, right?
Yeah.
So it's very complex, and some of the things that were meant to fund it, the Affordable Care Act, have never went into, were never rolled out. Some of the costs related to medical devices, the lobbies kept those they kept kicking them down, like they're not going to get rolled out this year, maybe next year, and they kept going down. And those were also things that would fund it. So yeah, you can see how the rationale behind that, because if you don't have these things that fund it, then okay. So we know that this is all kind of things that we've already talked about. So there's 5 components to the policy cycle that we'll just quickly discuss. So the first is issue raising. So this is the evaluation of a problem requiring a policy decision. So you first have to evaluate the problem. Policy design is that step of development of the proposal. Public support building, public appeals, and seeking support from interest groups. The 4th step is legislative decision making and policy support building. So this is to get support of key legislators, and you often have hearings related to a policy. Then the final one is just the decision making and policy implementation. So that's where we get to where we saw like the vote and then the presidential signature. And once a policy is made, then is signed, like a law, a bill becomes a law, then how that actually gets rolled out, the rulemaking and the allocation of resources has to happen. So often, once something becomes a law, you have to have the steps to the implementation as well. What we've seen and what has led, I think, to a lot of the failures with some of the repeal and replace was that a lot of these steps were really shrunk and concise. There may not have been hearings. They may not, time wasn't given to the support building that's needed, both the public support and the legislative support. And so that led to division within the Republican Party that didn't allow, as we saw, not enough votes to pass a repeal. And so, this policy cycle works when it's given enough time to work. But we're seeing this desire to rush a lot of these important steps, which if you don't go through the cycle, you may not be successful. Unless it's a policy with broad support across political ideologies and across the aisle, as they call it, across both parties. So there's different subcommittees, and that's really what the Schoolhouse Rock showed us that. The subcommittees, the Congress has three important powers. They make laws, they have the power to tax and the power to spend. So they have the power of the purse string, is what we often say. And they can use that power over the states as well. And so that's one way that the federal government gets states to do things that it wants it to do, is through the power of the purse string. So each, the House and the Senate both have different really important committees that relate to health. And so the three committees in the House are the Ways and Means Committee, the Energy and Commerce, and the Committee of Appropriations. So Ways and Means has the sole jurisdiction over Medicare Part A, Social Security, unemployment compensation, welfare, and healthcare reform. So when they talk about power in the House, the chair of the Ways and Means Committee, do you think they have a lot of power?
Yes.
Yeah, because they have sole jurisdiction over a lot of really important healthcare and public health programs or areas. And like we saw, not every bill even makes it to discussion. So the leadership in these committees play a role in what gets discussed in the committee, and therefore, if it makes it out of committee, what gets voted on. Energy is over Medicaid and Medicare Part B, public health, mental health, a list of other things. And the Committee on Appropriations is responsible for funding substantive legislative provision. So the Committee of Appropriations is very powerful across not only public health and healthcare initiatives, but really in general, it's a very powerful committee. So the Senate has two committees, the Committee of Labor and Health Resources, so that has jurisdiction of most health bills. So when the House and the Senate were trying to come to agreements on these different replacement bills, that work was happening in the committees, and so it was happening in the Ways and Means Committee in the House, and then the Senate was working at the same time on its own bill, and so then they'd have to come to congruence or come together on it. And the Committee on Financing, which has jurisdiction over taxes and revenue. So there are policies that have been enacted that provide access to care for specific groups otherwise unable to pay for or receive care. And so these groups include, and you'll be surprised that they are so similar to the ones we talked about in the first part of the class, poor children and poor adults through so for poor children it's Medicaid and S-CHIP, which is the state children's health insurance program. For poor adults, it's Medicaid and local and state assistance. For the elderly, it's Medicare. Persons with disabilities have access to lots of different programs. Veterans, through the Department of Veterans Affairs. The Indian Health Service provides service to Native Americans. And then patients with end-stage renal disease, including benefits for kidney dialysis and transplants through Social Security and Medicare. Did you guys find it interesting that like when you were doing your Medicare stuff, eligibility included that group?
Yep.
Why do you think they're in there? Like end-stage renal disease.
It's so expensive.
It's so expensive.
My best friend actually just gave one of her kidneys to her brother this week, and I mean, just the whole process of it.
Yeah.
It's so timely and so expensive.
There's a lot of expensive things in healthcare. There's other, like cancer, diabetes in general. No, I agree it is, but why them and not the others?
I think there was a lobbying.
Yeah. At some point, somebody added that one group, and they've for the reasons that you mentioned, and so it made sense. And they've been an ALS too, and has some eligibility. Yeah. So it's really interesting how I haven't looked into it how that happened, but because there's so much fascinating stuff on this policy piece around kidney dialysis too, because it's covered. There's a lot of expense that continues to go up with it, and a lot of it's covered because it's covered by all individuals with end-stage renal failure are covered. So that industry, dialysis industry, can be pretty lucrative if you work it out in a certain way. But there's a lot of lobbying that goes on to like subdivide certain people. And so these access to special groups, we talked about minorities and rural populations, so I'll just really hit very quickly on elderly. There are two main concerns that really dominate the debate of Medicare policy, and I think you guys alluded to these when in your case. And one is the viability of the program, right? Spending needs to be constrained, or should be restrained and constrained to keep the program viable. You hear a lot from the Speaker of the House about our children, and will they have cutting Medicare now for future generations to have access. But also another main concern is that the program needs to be truly comprehensive by adding services not currently covered. So you have these two sides, like constraining costs but expanding services. They kind of are not in alignment with each other, and so that's where you hear a lot of debate around those two. And so, as I mentioned, the National Health Planning and Resource Development in 1974. Who is that? Who did that one? 1974. Nixon. And so that was really the transition from improvement of access to cost containment. And so since then, that's been a principal theme of federal health policy, is trying to contain cost. Okay, policy and quality of care. AHRQ was created in 1989, and that has they're mandated to conduct and support research concerning outcomes, effectiveness, and appropriateness of healthcare services. AHRQ has plays a really important role. they have a very small budget though, so they only can do so much. Because they did establish funding for patient outcomes research, but they, compared to the NIH, their budget is very small. And when we think of, this is something we cover kind of more depth, is this crossing the quality chasm, which came out in 2001 from the IOM. And it really found that there were 6 areas for quality improvement. Safety, patients should be safe in healthcare facilities, and they should be just as safe as they are in their home. You should not go into a healthcare facility and be less safe than you are in your own home. Effectiveness is the healthcare system should avoid overuse of ineffective care and underuse of effective care. So we should really focus on what's most effective. It should also be patient-centered. So it respects the patient's choice, culture, social context, and special needs in the delivery of services. And I think the example that Mr. Youngblood gives about having all 12 desserts, you know, 7 desserts. I'm just really hungry right now. All 7 desserts. So, you know, you have to weigh effectiveness with patient-centeredness. So these are, you know, are not, you have to do this balancing act. Timeliness, wait times and delays should be reduced. And I feel like, Mr. Youngblood, was that one of the main things you were looking at with your study? What, the overnight studies that you were doing?
We're looking at, how acuity affects staffing.
Mm-hmm.
So,
yeah. So, I mean, that's something that you see from a quality director, focusing on this timeliness, cutting down the wait times. Efficiency. Always try this never-ending pursuit to reduce costs by curtailing waste, and being innovative. You know, however you can curtail waste being waste of supplies, equipment, space, capital, all waste wherever it is, and equity. So being equitable, providing care that doesn't differ based on people. Okay. So we will talk a little bit more just about healthcare reform. We know the criticisms, right? That we don't have universal health care. Our first attempt did not bring us to universal health care. There were major issues with how it was passed, and we're now seeing the dismantling or the rollbacks of some of the things around the Affordable Care Act. It's not perfect. It's time to think about how we can improve on it, or really have a true discussion at the federal policy level that allows for the policy process to work. Because if you talk to many providers, many administrators, they see the failures or the issues with the Affordable Care Act. It's going to be hard to go back. We'll never go back to pre-Affordable Care Act. We have to continue to evolve, and that process needs to be as transparent as possible at the federal level and allow for all the different stakeholders. This stuff, you can just read through it because it's really basic. All right, that's all I have for you guys tonight. Don't forget, we're in the home stretch, but there are still assignments, quizzes, homeworks due, so don't forget those. Have a great